So I'd like to welcome Richard Barlow to the stage here. Richard's going to talk about successful and safe teledermatology for low-risk skin cancer referrals. Thank you, Richard.
Thank you. So my name is Richard. I'm a registrar or a resident, as some of you might call us, in the UK. And thank you for letting me speak today. I'm going to talk us through the use of successful and safe teledermatology for low-risk skin cancer referrals. And after seeing a lot of the presentations this afternoon, I suddenly feel like our trust in East London might actually be a resource-poor setting. And it's been quite impressive to see all the other work that's been going on. So no conflicts of interest. We'll quickly talk through why we did what we did, the results of that, and what we plan to do with that going forward. So much like our speakers have mentioned before, we've got a big workload relating to skin cancer. In the UK, for those that aren't familiar, obviously you've got primary care, you've got your GPs, you've got secondary care specialists. GPs can refer anything that they think is a skin cancer to secondary care, to a dermatologist or registrars, consultants. And the target says you have to see them within 14 days, or the trust incurs a really heavy fine. So there's a lot of pressure in secondary care to see these patients, regardless of whether or not they're nonsense. As soon as they get that label, they need to be seen in 14 days. And especially since COVID, we're seeing at least 50% of our workload is these 2-week wait referrals. So that means that all your general patients are going down the bottom of the list. Obviously, we've got an aging population, like our speakers earlier said. So we've got a lot to see. So within the NHS, there's lots of targets to aim for, lots of papers, but 2 main papers in the last few years. There's a post-COVID recovery, how the health service will recover. Part of that outlines teledermatology is very important. And then there's also a paper 3 years ago called the Topol Review, and that basically outlined how the NHS, National Health Service, implements a digital workforce for the future. Both of these things say that we need to get telemedicine as part of your daily practice. So what we originally did a couple of years ago during COVID is to give our GPs or family practitioners, general practitioners, dermatoscopes. So we know that improves diagnosis, and that can aid us in helping them as well. The plan was for those individuals to take pictures using dermatoscopes and digital images, and just like our speakers earlier in the afternoon, the photograph quality was atrocious, so we could only use about 30% of these to make a decent diagnosis. And not only that, 2/3 of them only had enough information to even supplement it. So clearly we needed to think about something a bit more robust, but not quite as advanced as what you guys were implementing. Anyway, so what we did, we implemented a teledermatology service for skin cancer patients last year from October. I'll go through the criteria and how it worked in a bit more detail in a moment, but essentially we wanted to compare how those patients performed compared to the standard model of face-to-face reviews. Our managers are very much focused on how cost-effective any service is, so that was our main outcome for the managers. Anyone that went through this teledermatology pathway, they had to have either 1 or 2 lesions, no more. They had to be between 18 and 60, and obviously they don't want pictures generally of sensitive body sites, so things like genitals, those patients are excluded. If they didn't meet this criteria, they go through the conventional pathway of face-to-face. So the idea here is that these patients are low risk. Now, this is quite a complex diagram, but you can see on the far left the light blue box. You start with your GP, who decides that you might be looking at skin cancer, and they refer to secondary care. If you don't fulfill those inclusion criteria, you immediately get put into the conventional face-to-face. If you do fulfill the criteria, then you're scheduled to have a clinic appointment with a medical photographer. That medical photographer is based at our trust in East London, so they would generally come the patient on an afternoon at a weekend. Patient has their photographs, they complete a questionnaire. The questionnaire is kind of like serves as their history. The photograph gets uploaded with the clinical history, and then the clinician, such as myself or a consultant, so I'll always be supported by a consultant, or consultants do the lists independently, and that person will go through the list in their own time, not necessarily on that day, look at the photo, look at the history, and give an outcome. Those outcomes as you'll all practice yourselves, I'm sure, you either discharge the patient or you're going to schedule them for surgery or a face-to-face review. If they're going to have a face-to-face review or direct for surgery, then we tend to call those patients on the day, just so they're not kind of surprised when they get a letter. And then obviously you generate a letter from what you think the diagnosis is. So as I say, we collected this data from October to November last year when we rolled the service out. And we, for this purpose of the rest of these slides, we have, I'm going to call malignant lesions either a melanoma or an SCC. A non-malignant or a non-2-week wait lesion includes everything else, including basal cell carcinomas. And one of the slides earlier, someone I think had a slide saying that you're waiting 97 days for BCC to be biopsied. In our system, that's pretty quick. So, you know, we're waiting for some of these patients taking a year or two. So we're very different targets here. And all the information, and obviously this is retrospective, taken from electronic patient records. So again, quite a busy table here, but essentially what we're looking at is the column, or the first column, ignore that for a moment. The second column is all the patients that we saw through the Telederm service in October and November last year. So we had just under 300. They're all, on average, a bit younger than most of the comparative group, the face-to-face, as we would expect from those inclusion criteria. Slightly more female are coming through the service than males. And if we compare the first column to the second column, we can see that generally we're discharging about the same numbers from that initial review. So in the region of 50%. The main difference is in those numbers of patients that you're going to arrange a face-to-face review or follow-up. So in the Telederm service, you're going to have, or we had, a slightly lower threshold for arranging a face-to-face review because it's a new service and we obviously don't want to miss anything. And sometimes we might be a bit more confident in discharging or referring for surgery after we've seen the patient. The third column and the fourth column compare the face-to-face patients who are matched for age, so 18 to 60 versus the Telederm. And again, similar numbers of discharge. But again, we're going to see more of the Telederm patients face-to-face than the face-to-face original appointments. If we move on. This slide is to compare the outcomes of what happens. So you've seen your patient face-to-face, that's a conventional model, and we've compared that to your patient that's been reviewed for the first time in the Telederm setting. So you've seen the proforma or the questionnaire they've completed in conjunction with the photo that they've had. The bars at the bottom, discharge, you can see that there's not much difference between them, and that's not significant. So we're discharging about the same numbers of people. As I said, we're going to see more people follow up face-to-face in the Telederm setting compared to face-to-face. And that's probably because we're not as confident to refer them straight for surgery. So you can see that surgery, we refer slightly more people from the original face-to-face appointment. Just like to draw your attention to the top bar. So DNA, do not attend. We can have a lot fewer do not attends for the Telederm service, which has implications later for the cost effectiveness. When we compare these numbers for age-matched patients in the face-to-face service, again, we're seeing similar trends. So as I said before, if you've seen someone in the Telederm service and you've got a slightly lower threshold for seeing them face-to-face, before you decide if you're going to discharge surgery, what happens to those patients? And that's what this table is showing compared to those that you would see face-to-face originally. And actually, we probably do about the same sort of numbers once you actually see the person face-to-face. And about 20 to 30% are going to have surgery. The green boxes are just to show the outcomes of what we are actually diagnosing in these patients. And by and large, most of them are benign. I skipped over it before in the main table, but the diagnoses we're getting in the Telederm patients, the vast majority, over 90%, are benign. So if we come on to costs, I'm just going to focus on comparing costs of that outcome for discharge. So again, these are the patients we've seen in the first setting of Telederm, and they've discharged without being seen or had surgery, and we can going to compare that to the cost of those patients that we see in the conventional route face-to-face who are then discharged after that first review. And that's what this table shows. So obviously we don't need any nursing staff or healthcare assistants for that first teledermatology review. These are quite conservative estimates. So we've put here 20 patients for one telederm clinic. We're probably seeing about 25, sometimes even a couple more than that. Now we've got a bit more comfortable with the service. On the far right, you've got the column for the costs relating to that first face-to-face consultation or the conventional model. Again, conservative costs. We might sometimes photograph those patients, but we've said for the purpose of this, we've not included the costs here. And as you can see at the bottom, the blue boxes, about £20 to see a patient telederm, about 25 to see someone face-to-face. And when you consider that we're seeing so many more through telederm, these numbers really start to stack up and our managers really start to pay attention. If we now just focus on the costs of those patients that are eventually going to need surgery or are going to need to be seen face-to-face, I'm going to move past this slide because these numbers are what generate the table. These numbers are comparing those costs of the patients that we see overall, so the ones that have had either surgery or have been seen face-to-face. And the bottom row is the one that you need to focus on the most. So on average, a patient who completes the pathway face-to-face, so your conventional model, it costs about £72. And a patient who completes the telederm pathway, on average, costs about £54. So if you bring that all together, we can conclude that overall, we're saving quite a bit of money if we're implementing and continuing this pathway. And as I say, it's probably quite a conservative estimate, especially when you consider we're seeing so many more patients when we see them in the context of this teledermatology service. The outcomes, well, overall we have a similar rate of discharges, we're having similar rates of surgery, although we might need a couple of face-to-face appointments more in the telederm service. Although, as I say, now that we've got a bit more comfortable, that's starting to reduce. Lastly, limitations here. Well, it is a pilot study, so we have been more cautious. I've only looked at 8 weeks of data so far. And as I mentioned before, the telederm, we're seeing a much more higher volume of patients. And as I say, I skipped it over on that table, but we are seeing similar numbers of benign lesions versus malignant, and over 90% of these patients are going to have benign diagnoses. So thank you for your time. References.